Now, CHF can be described as the following, and a couple things that you want to pay attention to here. So please follow me. We'll begin with the left ventricle. The most common side of the heart to be affected will be the left side, as you know. Now, with CHF, you then divide it into systolic or diastolic dysfunction, depending as to what then led up into that particular type of failure. Now, take your time. If it's systolic dysfunction, I'm having a hard time ejecting. You have a hard time ejecting, meaning to say that you can't contract your heart. How does this occur? Maybe there was a myocardial infarction resulting in ischemia, obviously. And so therefore the heart no longer fully recovers its normal action, activity, and function. It may result in a systolic dysfunction. Is that clear? When you have a systolic type of dysfunction, you should automatically think and be looking ahead clinically, at least to the point where you know that your left ventricle has been enlarged, probably underwent eccentric hypertrophy, and PMI was probably what? Laterally displaced. Versus a diastolic dysfunction. Now, a systolic dysfunction, if I can't even eject the blood forward, what is the test that you're going to measure in which the blood gets ejected or not? It's called ejection fraction. What does that equal? It equals your stroke volume over your EDV. What is your stroke volume? It is your EDV minus your ESV over your EDV, right? That's your ejection fraction. It's a fraction. You get a percentage, and that would be 55%. If it's systolic dysfunction, your ejection fraction plummets immediately. You know without a doubt that your patient has heart failure. Now, that's the easy diagnosis. The one that you want to be a little bit more careful is based on history. Everything's based on history. With diastolic dysfunction, it's a very thick left ventricle. Or maybe perhaps there's too much blood in your left ventricle. Let's deal with the one in which your left ventricle wall is thickened. Secondary to pressure, pressure, pressure. Where does pressure come from? Most commonly, hypertension, right? And what kind of change and what kind of hypertrophy would you have in your left ventricle? Concentric hypertrophy resulting in decreased chamber size. So therefore, you cannot properly fill up your left ventricle. What do we have, ladies and gentlemen? A diastolic dysfunction. Early on in hypertension or aortic stenosis, which would still be what? A pressure overload type effect where on your left ventricle, is it possible early on that you may be able to properly preserve your ejection fraction? Yes, you can. You can preserve your ejection fraction. Welcome to HF, heart failure. P is preservation. EF is ejection fraction. All right? That's what the abbreviation means, and that's what you're going to use clinically. You walk into any cardiac clinic, and you tell them exactly what I told you. You'll be a star. And once you make that first impression, that's it. That's it. No one's going to doubt you. Next, right ventricle. Most common cause of right heart failure, or HF, is LHF, which is left-sided heart failure. Let me ask you this one more time. Is this cor pulmonale? You will tell me confidently, no. If you haven't, you do now. If you have primary lung disease, and then you have right-sided heart failure, and then you call this cor pulmonale. Pressure volume overload right ventricle from the overload of the LV. And we talked about this a few times, and if you get into right ventricular failure, that is not good news for the patient. Is that clear? Bad prognosis. Biventricular, obviously both ventricles are going to die. So you pay attention to left ventricular failure first. Make sure you know firmly the difference between systolic and diastolic dysfunction. Once you get that down, right ventricular failure, pretty straightforward. And then biventricular, where both ventricles are going to die.